This video will be about bleeding disorders. So we begin bleeding disorders by classifying them depending upon which part is abnormal. So they are classified as either due to abnormality of the platelets, or there could be abnormality of the clotting factors, or the bleeding disorders can occur in a mixed variety where both the platelets and the clotting factors are abnormal. So mixed variety is seen in a condition called as DIC, that is disseminated intravascular coagulation. Whereas platelet disorders and clotting factor abnormalities, we will discuss them in detail. Now, why is it important? Well, to understand bleeding disorders, it's important for us to know about the normal hemostasis pathway which is occurring, which involves a primary hemostasis, which is a function of the platelets, and then it is followed by a secondary hemostasis, which is a function of the clotting factors. So if the platelets are abnormal, the primary hemostasis is involved, and if the clotting factors are abnormal, the secondary hemostasis is involved. So we need to have a basic idea of the hemostatic pathway, and I have done a separate video on this on the physiology section. I'll put the link to that in the description, so do watch it to understand the bleeding disorders better. Now, one point which we need to understand is that there are lab parameters which indicate platelet function, and there are lab parameters which we check for clotting factors. So for platelet function, obviously we'll be checking the platelet count, that is our first parameter, and then we'll also check the bleeding time. So bleeding time is an indicator of platelet function. What about the clotting factors? For the clotting factors, we check the partial thromboplastin time and we check the prothrombin time. Now the PTT, or the activated partial thromboplastin time, it is an indicator of the intrinsic pathway. To understand what an intrinsic and extrinsic pathway are, we have to refer back to the video on hemostasis, whereas prothrombin time is an indicator of the extrinsic pathway. I'll just mention which are the factors which are involved in both of these pathways. So for prothrombin time, the factors involved are factor 3 and 7. Whereas for the PTT, the factors involved are 12, 11, and 9. These are the factors which are involved in the intrinsic pathway. So that's about it. Two more points which we need to realize is that, one is that for platelets, in platelet disorders, the presentation is going to be in the form of superficial bleeding. So the patient will present with superficial bleeding, which is in the form of petechiae, ecchymosis, and so on. Whereas in the case of clotting factors, the bleeding is going to be in the form of deeper bleeding, that is into the muscles and the joints. So there will be hemarthrosis and so on, and hemorrhages in muscles and so on. So that's about a basic introduction into the bleeding disorders. Having said that, we now move into platelet disorders proper. So the disorders of platelet could be again classified into either there is a deficiency of the number of platelets, that is there is a quantitative disorder, or then there could be a qualitative disorder. Amongst the quantitative disorders, there are a number of conditions. I'm not going to mention everything, but in this video we'll be discussing about the important one, that is immune thrombocytopenic purpura. So that is a qualitative deficiency of platelets. Now let's discuss about immune thrombocytopenic purpura. The age it affects is usually children, and the sex is females are more affected than males. The etiology, and why does ITP occur? ITP occurs either it could be idiopathic without any reason, that is the primary cause, or secondary it can occur to viral illness. This occurs mostly in children, but it can also occur in certain malignant conditions and in autoimmune disorders. Now, what is the pathology or the pathogenesis which is occurring? What happens is that because of viral illness, malignancy, or autoimmunity, there are going to be antibodies which are formed, and these antibodies are produced against the GP2B3A receptor of platelets, 3A receptors. So to understand that, we have to know that if this is a platelet, it has two receptors. One is the glycoprotein 1B receptor, the other one is the glycoprotein 2B3A receptors. These two receptors have important functions in the hemostatic pathway. The glycoprotein 2B3A receptor is involved in platelet aggregation. So when antibodies bind to this receptor, it will prevent platelet aggregation, and that will stop the primary hemostasis. And also what happens is that the antibodies which are bound to the glycoprotein 2B3A receptors, they are identified by the splenic macrophages, and then what happens is that these platelets will undergo phagocytosis by the macrophages, and that will lead to thrombocytopenia. So this is the mechanism in ITP. Now, how do we diagnose it based on the laboratory findings? So in identifying the bleeding disorders, as I've said earlier, we'll have to do both platelet function test and about the clotting function test. Naturally, what will happen to the bleeding time? Coming to the platelet function test, the bleeding type will obviously increase because of a deficiency of platelets. The platelet count will definitely decrease. What about the clotting factors? There is no issue whatsoever with the clotting factors. So both the intrinsic pathway and the extrinsic pathway indicated by PTT and PT respectively will be normal. What about the peripheral smear? In peripheral smear, you will see thrombocytopenia, which is the important feature. And if you do a bone marrow examination, in the bone marrow, we can see an increase or a compensatory increase in the megakaryocytes, which are the precursors for platelets. So that's about immune thrombocytopenic purpura. Now, how do you treat it? One mechanism is by splenectomy, which can be done. The reason is obvious because spleen is responsible for phagocytosis, and if you remove the spleen, that mechanism is stopped. So one is splenectomy. If it is an autoimmune condition is the cause for ITP, where ITP can occur secondary to autoimmune conditions, then we can give glucocorticoids and anti-immunoglobulins, IVIG. So these are the treatment mechanisms for ITP, and that's about immune thrombocytopenic purpura. Now we move on to the qualitative disorder, and we'll just have to know a few important points about these disorders. So what I have drawn here is, this is the endothelium, and below the endothelium we have the subendothelial collagen. Now, when an injury occurs in the endothelium, the von Willebrand factor, that is VWF, will bind to the subendothelial collagen, and the subendothelial collagen is linked to the platelets through the von Willebrand factor, and that linkage occurs through the GP, glycoprotein 1b receptor. And after this process occurs, the platelets are activated. They will undergo platelets secretion, where the platelets will secrete the granules present inside it, and it will activate the surrounding platelets, and finally these platelets will aggregate via the glycoprotein 2b or 3a receptors. So three important parts are responsible for deficiency in a platelet function. The first one is von Willebrand factor. If there is a deficiency of von Willebrand factor, that will lead to von Willebrand disease. So that is one disorder. We'll just have to know the names. And secondly, if there is a deficiency of the glycoprotein 1b receptor, which binds the platelets to the subendothelial collagen, so if there is a deficiency, that will lead to a condition known as Bernard-Solier syndrome. So that is the second disorder. And finally, if the glycoprotein 2b3a, which is responsible for platelet aggregation, is involved, or when there is a deficiency or defect in that receptor, that will lead to a condition known as Glanzmann's thrombasthenia. So you just have to know the names of these conditions. That's about the platelet function disorders. We have three disorders. Having said that, we now move on to the next topic, which is the clotting disorders. When it comes to clotting disorders, we will be discussing about firstly hemophilia, and then we'll be discussing about vitamin K deficiency. These are the two clotting disorders which are going to be discussed. We begin with vitamin K deficiency. Vitamin K is responsible for the activation of the four important coagulation factors, which are the factors 2, 7, 9 and 10. In vitamin K deficiency, there is therefore going to be an abnormality of coagulation. So there is going to be a decrease in coagulation or clotting factors with a normal bleeding time. So the bleeding time is going to be normal because the platelet function is not affected. The next disorder is hemophilia. So let's discuss about that. Now hemophilia occurs in three types. That is, there is hemophilia A, depending upon the clotting factor which is involved. Then there is hemophilia B and hemophilia C. In hemophilia, there is going to be a deficiency of one of the clotting factors, and depending upon which clotting factor is deficient, we name it as A, B or C. In hemophilia A, The clotting factors which is deficient is factor 8, whereas in B the deficient factor is factor 9, and in C the factor which is deficient is factor 11. Now the factor 9 and factor 11 that is involved in intrinsic pathway, whereas factor 8 it is common to both pathways. So that's one point to remember. Now hemophilia B is also has a different name. It is known as Christmas disease because factor 9 is called as Christmas factor. Therefore deficiency of factor 9 will lead to is also known as Christmas disease. The other important point to understand is that these are hereditarily inherited usually, but sometimes hemophilias can also occur de novo, which means that absence of a family history does not always rule out hemophilia, even though in most cases there is going to be a family history. Now hemophilia A and hemophilia B, these two are X-linked recessive disorders. They are X-linked recessive. What it indicates is that when we look at the pattern of disease in males and females, what happens is that males end up having the disease, whereas females will act as the carriers. And we all know the reason why, because females have two X chromosomes. It's a recessive condition. One X chromosome will compensate, whereas in males there is only one X chromosome. So even recessive conditions will appear in males. What are the features? I have said in the beginning that clotting disorders will present with features of deep bleeding, which will include bleeding into the joints, most commonly that is hemarthrosis. There will also be increased bleeding after trauma or surgery. So there is going to be excessive bleeding. So these are some of the features of hemophilia. Easy bruising can occur, and in normal conditions where bleeding should actually stop, that does not occur in an individual with hemophilia. Now we look at the parameters. What will happen to the platelet functions? Obviously the bleeding time should be normal because it is not affected. The platelet count should also be normal. When we come to the clotting factor abnormalities, the PTT will increase. Why is it so? It is because the intrinsic pathway indicates, PTT indicates functionality of the intrinsic pathway. So the intrinsic pathway is damaged in hemophilia, whereas when it comes to the prothrombin time, it could be increased or it could be normal, because the prothrombin time is an indicator of the extrinsic function, so that should be normal. Apart from this, whichever factor is involved, depending upon the type, that factor will be severely deficient. So whether it is factor 8 in hemophilia A, factor 9 in hemophilia B, or factor 11 in hemophilia C, so that will be deficient. So that's about the lab parameters. And what about the treatment? The treatment will be replacement of these factors. So you could use a concentrate of whichever factor is deficient, that is factor 8 or 9 or 11. Along with that, desmopressin is also known to be effective because desmopressin causes the release of von Willebrand factor and factor 8. So desmopressin is effective in hemophilia A. So that's about hemophilia. Now we speak about a disorder by the name of disseminated intravascular coagulation. There are so many causes which cause DIC, and it is a really serious condition. When we speak about the pathology of DIC, what happens here is that there is going to be a widespread hypercoagulable state which occurs because of several causes which we'll mention next. And to understand hypercoagulable state, we all know about Virchow's triad, right? That is changes in the endothelium or stasis of blood or hypercoagulability. So because of the disorders in any of these three parts of Virchow's triad, a hypercoagulable state is produced, and as a result, due to the formation of extensive thrombi, the clotting factors and the platelets are consumed extensively. So these platelets and clotting factors are consumed to form clots in hypercoagulable state, and as a result, what happens is that they will get depleted, or there will be deficiency of clotting factors and platelets due to the excessive consumption, leading to thrombocytopenia and clotting abnormalities. And this kind of abnormality is known as conceptive coagulopathy. That is because of the consumption of clotting factors and platelets. It is known as consumptive coagulopathy. Now, as a result of this deficiency, then there will be secondary hemorrhages, microhemorrhages will occur. So this is the pathogenesis which happens is disseminated intravascular coagulation. Now, what causes DIC? There are so many different causes. First one is in obstetric causes, amniotic fluid embolism. The other common causes are sepsis. Sepsis causes bone marrow suppression as well. Then it could occur in snake bites. Some of the malignancies occurs in acute pancreatitis. There are so many conditions causing the hypercoagulable state in DIC, and it could occur in blood transfusions or traumas. So these are some of the conditions which cause disseminated intravascular coagulation. Now, what happens to the lab parameters? Both the platelet function test and the coagulation function test are abnormal. The bleeding time is prolonged. The platelet count is decreased. Both PTT and PT are increased. In addition to that, some of the other parameters such as the fibrinogen will also get consumed. That will be decreased. And the fibrin derived products and D-dimers. These two substances are found when the fibrin is lysed by the plasmin, that is a fibrinolytic system. So since large amount of clothes are found, large amount of clothes are also cleaved by the fibrinolytic system. Therefore, these fibrin degradation products and the D-dimers will increase. If we look at the peripheral smear, there is going to be schistiocytes. These are found in microangiopathic hemolytic anemia. What it means is that between the clots, when the RBCs pass between the clotted blood vessels, it will break down into irregular fragments, and such cells are called as the schistiocytes, and they indicate microangiopathic hemolytic anemia. So that is about disseminated intravascular coagulation. Now we'll just discuss in brief about some of the other disorders of bleeding, and it's just going to be a brief disorders. So we have some thrombotic microangiopathies such as thrombotic thrombocytopenic purpura, and then we have another condition known as hemolytic uremic syndrome. The important point is that these two syndromes are very similar to DIC. They will present similar to disseminated intravascular coagulation. The difference is that in these conditions, the platelet functions are going to be really abnormal, but somehow the clotting functions are not as abnormal as in DIC. The PTT and prothrombin time are still normal, and it is not as abnormal as in DIC. Now, what are these conditions? The first one is TTP. Here what happens is that there is going to be extensive thrombosis, and as a result of thrombosis, it will lead to the consumption of platelets leading to thrombocytopenia. That is why it is known as thrombotic thrombocytopenic purpura. However, the clotting factors are not much consumed as in DIC. Therefore, the coagulation factor tests such as PTT and prothrombin time are going to be normal. Now, why does the thrombosis occurs? It occurs due to defective degeneration of von Willebrand factor. When the von Willebrand factor is not properly degenerated, it will form large multimers which will activate the platelets, leading to platelet adhesion and aggregation, and that will lead to thrombocytopenia. Now, the degeneration of von Willebrand factor is actually by an enzyme called as, with this big name, that is ADAMTS13. So if this enzyme is deficient, or if there are antibodies to this enzyme, then there is going to be defective degeneration of von Willebrand factor, and that will lead to TTP. Hemolytic uremic syndrome is very similar to that of thrombotic thrombocytopenic purpura. It is just differences in presentation. Also, in history, there is going to be an infection with a Shiga toxin producing E. coli, and that will lead to the thrombotic state, which will damage kidney and lead to acute kidney injury. So that's a short description about these two disorders, that is TTP and HUS. Now we end this video with thrombophilias. So far we have discussed about bleeding disorders where there is going to be excessive bleeding. In thrombophilia, there is going to be excessive coagulation. It's the opposite, that is, it's about a persistent hypercoagulable state. And we are going to discuss some of the inherited thrombophilia. To understand that, we need to know anticoagulants, the normal anticoagulants in our body. So if these normal anticoagulants are deficient, that will obviously lead to thrombophilia. The normal anticoagulants in the body are, we have antithrombin 3, then we have protein C, we have protein S. If there is a deficiency in any of these conditions, if there is hereditary deficiency of any of these three molecules, that will lead to thrombophilia. So there could be antithrombin 3 deficiency, protein C deficiency, or protein S deficiency leading to thrombophilia. There's a special type of thrombophilia which is known by the name of factor V Leiden. What it means is that normally protein C is responsible for degrading or cleaving factor V and inactivating it, but here a point mutation occurs in the factor V in the DNA, and as a result the factor V becomes resistant to the action of protein C, which will lead to hypercoagulability. So that's about bleeding disorders, and that's it for this video.